I hope over the next 15 or 20 minutes, Lizzie and I are going to convince everyone, or anybody who needs to be convinced, that a further liberalisation of the use of clear fluids before theatre is safe, justified, medically defensible, and the right thing for our patients. I'm going to hand over to Lizzie to start the presentation.
So hi, good morning. I'm Lizzie. I'm one of the CT1s here. So we can have a bit of a chat about SipTilSend. So have a bit of a chat about what we're doing already, why we're doing that, and what we hope the next steps are. Initially, we sort of had our nil by mouth guidance from these couple of statements, which were due to reduce the amount of stuff. Vomiting, and then about 60 years post that, Mendelssohn had looked and coined the sort of syndrome, which is aspiration, and said that was due to aspiration. These are the numbers and why we think that it's important to have some measures to prevent that. NAT4, which looked at critical airway incidents associated with anaesthesia, it was responsible for about 50% of those deaths. And still sort of a main cause of death associated with anaesthesia. So we know that severe aspiration is related to these factors. Some of the research methods that we have looked at papers using to measure the gastric volume and aspiration involved ultrasound, which has been shown to potentially be promising for pre-op assessment. And we've also looked at a paper including MRI as well. And just as an aside, so it's been shown that even with fasting, there's a baseline secretion of your gastric acid, which shows that even once you've been fasted completely, you can have up to 1.5 mils per kg. And actually, it's been shown that drinking water can actually increase your pH, so make it more alkaline and lower your gastric volumes preoperatively. So a couple of graphs. So one on your left shows gastric emptying with various fluids, and those are based on calorie density. So the bottom one, you've got the one that's emptying quickest is your water, and then with raising calorific content, you've got some orange juice and sugar and some milk up there as well. But the main thing that we're concerned about, you can see in the graph on the right, which is that very quick initial half-life of clear fluids in the stomach, so about 10 to 15 minutes. And so the one on the left was done on some ultrasounding of the stomach, and on the right was an MRI study of the abdomen of healthy volunteers. And the other thing that we're sort of interested in as well is this ongoing fast phase of your gastric emptying. So this is a paper, 600 ml bolus initially, and then 150 ml boluses after each 20-minute period. And that again shows that there isn't the sort of concerning build-up with the repeated ingestion. There's this continued fast emptying of the stomach. So what are the international guidelines? I don't expect you to read all of that immediately, but essentially it's fairly similar to ours in that we have 2 hours for clear fluids and 6 hours for eating. One notable exception on this page is the Scandinavian Society, which I'll touch on slightly later as well. And as a note, the most recent guidance from the paediatric societies has reduced the fasting time to an hour for clear liquids for children. So what we're doing so far is essentially, as I say, a mock-up of the international guidance. So 6 hours food pre-op, and then fluids, clear fluids, 2 hours with a bit of milk in your cup of tea or coffee if you want it. We also have Think Drink as our initiative, which aimed to reduce the adage of nil by mouth for midnight, which we recognised was detrimental for patients. So that's encouraging fluids up to 2 hours pre-op and trying to encourage anaesthetists to recognise that and sort of work with ward staff in terms of allowing patients to eat and drink up to the latest time. which would be 2 hours pre-operatively. It's worth noting that we've already got some discretion in there. So in emergency cases, fluids can be offered at the discretion of the anaesthetist, and down there in practical points as well, sips of water may be allowable within that 2-hour window. So we've already got some element of choice in there for the anaesthetist. The audit that we carried out in January was of 100 patients, just over 100 patients in QMC recovery, looking at how long fluid fasting times were, and we looked at that in terms of emergency, elective and trauma cases, and which specialities as well. And the results speak for themselves. So the mean time for fluid deprivation was just under 7.5 hours, with a slightly reduced time in trauma and elective cases, which I was just chatting to Will, may have been due to the fact that some people are already starting to use that discretion, and a slightly longer time in emergency cases, with obviously the longest time there being 38 hours, which was due to a patient who'd had rolled surgeries from very previous days on the emergency list. So Teesside was sort of the initiator of this and did a similar audit to ours, and actually got fairly similar results in that their mean fluid deprivation was about 7.5 hours, with repeating fasting, and showed sort of a poor patient overall experience. They asked their anaesthetist would they be happy for patients to have 170 ml an hour of water prior to surgery, and that's an hour, and a small amount of milk with their tea on the start of the day. King's Lynn have a slightly more conservative approach, so they allow patients to receive 50 ml of water orally per hour, and that's in all elective and emergency cases, with some sort of reasonable exclusions down there at the bottom. So what is everyone else doing? So already some people are using it in NUH informally, and it's available for trauma patients in some other areas of the UK. In Australia and New Zealand, there's sort of interest, but nothing formal. And again, the Scandinavian Association I mentioned earlier is a bit more flexible and allows for about 150 ml of water for an hour prior to induction.
So I'm going to talk very briefly about our proposal, really. So I think it's very evident what the problems are with the 2-hour rule. Certainly, I think there's big logistical problems with actually ensuring that fasting doesn't increase beyond that. We can see that from the audit data. It's been the case forever, since 1946 probably. 2 hours is almost never 2 hours. And we still have a cohort of patients who haven't had a drink in the morning for whatever reason. They so often tell me that. And it can be difficult, even with Think Drink, to make sure that those patients consistently get a drink. It also doesn't really make sense in adults having a 2-hour rule when in pediatrics we've adopted the 1-hour fasting time. We know that children actually have a higher risk of aspiration than adults, and yet they have a more liberal fluid policy. And I think that's probably just simply a case that none of the associations have grasped the nettle of the adult guideline yet. The main reason for them liberalising the fluids in paediatrics, as I understand it, is that aspiration of clear fluids, even when it does happen, is very rarely associated with severe harm compared to aspiration of solid material, which is often associated with death. And it normally just requires an increased period of monitoring and sometimes some antibiotics. And Lizzie's already shown that actually drinking small amounts is probably inconsequential. What's the problems with changing just to a 1-hour rule for adults? So Monty Mython in 2020 wrote an editorial arguing for a liberalisation of the adult guidelines to be the same as the paediatric ones. I think the problem with that is that the logistical issues still remain. Determining who can drink to when, it would be a little bit easier, but there would still be confusion and problems. 1 hour can still become many more. And actually, is it a safer scenario than a SipTilSend scenario? I'm not so sure. There's potential that somebody could be drinking large unregulated volumes 1 hour prior to surgery, rather than actually a monitored small volume where they're encouraged to sip it. So what are the arguments for SipTilSend? So NHS Tayside have recently shown their patient satisfaction survey. Unsurprisingly, patients are happier. They felt less dry. A number of patients reported lower levels of anxiety. And of course, we'd hope that there would be some improved hydration. Now, most of the studies that have looked at pre-op fasting and cardiovascular parameters, hydration status, haven't found any positive results, but they've normally looked at a control population with a 6-hour fast time in ASA 1-2 patients, not the 95-year-old who's been fasting for 25 hours before their fractured neck of femur. Many of us are already doing it safely, and there's a number of people here who are already embraced SipTilSend, and in fact, if you say that to the trauma coordinators, they know exactly what you're talking about. In terms of the medical legal defence of us deviating from national and international guidelines, we won't be the first trust, and therefore we fulfil the Bowden principle. And I hope that we are arguing that this is a logical, reasonable and defensible change, and therefore it'd also be compatible with the Letho judgment. What are the arguments against? I mean, I can't really think of many. Of course, change involves implementation. It involves perhaps some initial confusion about what people can and can't have. It would certainly require, just like Think Drink, a campaign to improve awareness and understanding. But really, the only major argument against is it's deviating from currently accepted national society guidelines. But as I've argued, I don't think that really has any significant implications for the trust or the individual anaesthetist whatsoever. So what are Tayside actually doing? Well, they're saying that a standard cup, NHS cup, is 170 mils, and they allow people to sip that up to that amount every hour. And in fact, they allow clear fruit juices, which is interesting. We don't allow fruit juices, only squash and cordial. With the 2-hour rule at the moment. And they also allow tea and coffee, so you could sip a cup of tea and coffee. It's not clear from what I've seen whether or not they allow milk with that. They include their emergency surgery patients, and they acknowledge that bespoke guidelines may be required for the individual patient. They have this statement is verbatim from them. What they don't tell people is what they need to do for these patients who are determined to be at increased risk. Personally, I think I'd still be happy to give these patients, the diabetic patient who may have gastroparesis, the sips of water. I don't think that makes any significant difference to either their aspiration risk or the consequence if they were to aspirate. So our proposal is to keep the NUH fasting policy and Think Drink otherwise unaffected. Think Drink is obviously still essential. I think it's really important that people are offered a cup of tea or coffee, etc. This shouldn't have any impact on that. And I think 170 mils an hour is reasonable, but I personally think that for clarity, beg your pardon, we should be keeping this just to water. It should be very simple that they're offered a small glass of water every hour where possible, and that these patients should all be in the pre-op lounge or wherever they are in hospital. This shouldn't be something that's being encouraged for people to do before they arrive, so they get the same fasting instructions, and it's something for the ward staff. And I think it's reasonable, like Tayside and like King's Lynn, that all adult patients are included, and then it's left to the discretion of the anaesthetist whether or not they want to add additional rules, or potentially for some patients they might say, yes, you could have some squash because whatever, you suffer with hypoglycemia. So I was hoping that we could just do a very quick survey in the chat function here. And really all I'm asking is if you will be identifiable. So maybe people don't want to put no, they wouldn't support it with their name to it. But I'd be interested to know how many of the people on this chat would be happy to say yes, they would support adopting a SipTilSend policy at NUH. And then moving forward, if there does appear to be a consensus support of it, we'll be trying to move it through governance, this summer. I know that many members of the department already support this, so I'd be interested to know what people's concerns are. Thank you, Steve. Thank you, everyone, for listening. Thank you, Lizzie.